Welcome back, everyone. We're making the final turn on a great day of teaching and conferences. It is my pleasure to introduce Dr. Ciro Esposito, Chief of Surgery in Naples, Italy, to discuss a topic that I love, ICG fluorescence in pediatric surgery. Ciro, thank you for being with us.
Thank you very much, Mac. Thank you very much, Todd. It's a pleasure to be with you and to share my experience in ICG fluorescence technology. I have some slides with videos with 3 cases that we can discuss. First of all, I have nothing to disclose, and only a short introduction. As you know, in particular in pediatric MIS surgery is important to detect anatomic structure, above all to reduce the incidence of complication. For this reason, the imaging technology has to help us as pediatric surgeons to do this. In the last 3-4 years, we use in our operative room the near infrared indocyanine green fluorescence imaging technology that is very useful in different indications, and is ICG in a soluble molecule that is rapidly bound to albumin and is near instantaneously visualized with target organs, and it is removed from circulation by the liver and bile juice. For this reason, one of the main indications is the surgery of gallbladder. To use this technology, you can adopt this technology, use laparoscopy, and you need an optic, you need for sure a camera, a vial of ICG, but you can use also in robotic surgery because above all the last generation of Da Vinci Xi system is a system called Firefly that can adopt ICG. I have 3 cases that we can discuss together. There are three classic indications that I adopt in my clinical experience. The first case is a 12-year-old boy, a little bit fatty, of 70 kilos, with gallbladder stone disease, and at the ultrasonography has several stones in the gallbladder. He had several episodes of upper right quadrant pain, and we have to decide what to do. Which is the diagnostic workup before surgery or during surgery, and above all, which management is indicated. The first possibility can be ultrasonography and then medical therapy. As you know, sometimes pediatric hepatology give for these children also the ursodeoxycholic acid therapy for some weeks. The second option is to use preoperative US and then to perform the old-fashioned laparotomy to remove the gallbladder. Then another alternative is to perform preoperatively cholangio MRI and then to perform a laparoscopic cholecystectomy, or the classic preoperative US and then start on laparoscopy, or preoperative US and then laparoscopy but using ICG technology. I don't know if we can discuss a little bit, and then I will show some slides as which is my aptitude in this case.
Well, I suspect at this point people know that the right answer from you is E. But if anybody wants to weigh in on another comment about other therapy, please do so.
Yes, I agree completely with you. If you haven't ICG system in your hospital, some colleagues prefer to perform a preoperative cholangio MRI to have a clear anatomy of the biliary tree to avoid complication. If you haven't, you have to perform US and the standard laparoscopy. In the last 3 years, we use ICG technology. For this reason, as you told us, we prefer E, the preoperative US and then laparoscopy using ICG technology. Why? Because if you analyze the international literature, above all in adults, there are a lot of complications in laparoscopic cholecystectomy. And this is particularly true in pediatric patients because, as you know, compared to the adults, as you can see in these slides, the adults perform about 100 to 300 cholecystectomy per year in an adult center compared to a pediatric center in which we perform 10 to 30 cholecystectomy per year. For this reason, the learning curve is a little bit longer. And above all, if you find this case, as you can see in this slide, in this video, there is a complex case in which the anatomy is not clear because you don't know where is exactly the cystic duct, the main biliary tree. You can have the complication. Thanks to ICG, you can have a real biliary mapping during the procedure. And the ICG is in vial of 25 milligram per milliliter. You have to dilute the vial with 10 milliliter of sterile water, and then you have to inject 6 milliliter of ICG intravenously the day before surgery, above all 12 to 15 hours preoperatively. In this way, you have a clear view. As you can see in this video, this is the ICG technology. You can see very well the biliary anatomy is absolutely amazing. As you can see, the main biliary tree, the gallbladder, and then the cystic duct. And you can perform a safe dissection. And also in this other case, as you can see, there is a lot of adhesions. And if you adopt ICG technology, you can see that there is an angulation of cystic duct with the cystic fundus. And thanks to ICG, you can switch to a normal view, to ICG view, and to perform a very good isolation. And above all, you have always a very good view of main biliary tree. And this is a huge advantage during laparoscopic cholecystectomy, above all for trainees. In this way, you can lower to zero the complication. For this reason, I think is an amazing technology to adopt. Now you have a new ICG system, because the old ICG system, you have to switch with a pedal and you see the picture in black and white. Now, with the new Rubina system, you have the possibility to remain in color, and the biliary tree is colored in green. It's absolutely amazing. I think then thanks to this system, you can lower the complication to zero because you have a very clear view of the anatomy. As you can see in this picture, it's impossible to have a complication. The main drawback of this technique is that you have to inject the product the day before surgery. For this reason, you have to plan in advance ICG technology for cholecystectomy. And in my center, we use this technology routinely now for all the gallbladders. And this is the first case. I don't know if you want to ask something or want to pass to another indication. As you know, as you prefer.
I think because of time limitations, we need to move ahead. But
okay, perfect.
I'd like everybody to be thinking about when you give the ICG. The idea of giving it a day ahead of time kind of was new to me. So let's keep going though.
Okay.
That's an important point, Mac, that I'm glad you brought up because I didn't know that either.
Yes, as I told you, you have to plan the use in about the indication of ICG, because the cholecystectomy is the only pathology in which you have to use to inject the product in advance. Because in other indication, as you can see, for kidney, for lymphomas, or for varicocele, or for other indication, you have to use this intraoperatively. For this reason, it's easier. for cholecystectomy, you have to plan in advance. Why? Because if you use intraoperatively, you can see mainly the liver, because it's taken by the liver and you have the liver in green and it's difficult to identify the gallbladder. After 12, 15 hours, there is a secretion of ICG in the bile juice and you see electively the biliary tree. For this reason, this is the only indication to inject ICG in advance. The other indication, as you can see in next slides, you have to use this technology intraoperatively. For this reason, for the surgeon is easier.
So can I just clarify that for elective cases, you bring the patient in the day beforehand to get injected?
Yeah, absolutely. We is hospitalized the day before surgery. In the afternoon, we perform the injection. In the late afternoon, if is operated early in the morning.
For some of our liver cases, we have them come to clinic and we give the injection in clinic, and then they can come back for surgery the following day.
Yeah.
To avoid the additional hospitalization day.
Let's keep going.
Okay. We can move to the second indication of ICG. We move from GI to urinary tract. This is another classic example. Is a 27-month-old girl of about 10 kilos with a duplex kidney with a non-functioning lower pool secondary to reflux. He has an ureterocele already treated using endoscopy in neonatal period, and now she has a urinary tract infection and urinary incontinence, probably for an ectopic ureterocele. As for the diagnostic workup and management indicated, there are several options as usual. There are scintigraphy and then clinical control plus antibiotic therapy, considering that ureterocele was already treated at birth. Then the other option, scintigraphy and partial nephrectomy using the old-fashioned laparotomy. The third option is scintigraphy, because scintigraphy is essential to check the function of the moiety that we have to remove. And partial nephrectomy via retroperitoneoscopy. The option D is scintigraphy with partial nephrectomy using robotics. Also, if there is a weight limit, because as you know, robotics you can use in general in patients higher than 10, 15 kilos, or you can use scintigraphy in preoperative for operative workup, and then partial nephrectomy and via laparoscopy using ICG, and I will show you why.
It looks like in the poll results that most of them are saying that the last choice, using laparoscopy with ICG, over 70%.
Yes, I think that this is the right answer, because in laparotomy, I think is not no more indicated to perform partial nephrectomy. Using via retroperitoneoscopy, there is the problem because this child has a reflux and it's difficult to remove the last part of the ureter. And via robotics, at the moment, the robots on the market is huge for this kind of children. For this reason, we prefer to perform the procedure in laparoscopy. And we use ICG. Why? Because you have three main advantages using this technology. First of all, you have the possibility to identify the ureter, because when we perform a partial nephrectomy, we put via cystoscopy at the beginning a catheter in the ureter. And as you know, when there is a duplex system, the two ureters are attached to each other, and using ECG, injecting the catheter, you can identify the normal ureter that you have to save. Then you can clearly identify the vascularity, the vascularization of the kidney, and above all of the kidney that you have to remove, as you can see in the slide. And the third advantage is that you have to inject the third time intravenously ICG, and you can identify after clipping the vessels of the moiety that you have to remove, there is the vascularization line. And you can see this is the videos. This is the old system in which you see in black and white, but you can see very well the ureter, the normal ureter that is green. The ureter is attached, and thanks to ICG technology, you can identify the ureter that is attached to the normal ureter. With the pedal, you can switch from ICG view to a normal view, and you can start the dissection. As you can see, the normal ureter is very small, and you can see in green, and the other is very big. If you switch to normal view, it's difficult to identify. The second aspect, you have to inject intravenously 2 milliliters of ICG solution, and you can see the vascularization of the kidney. As you can see, this is the classic vascularization of a duplex kidney. You have to remove the lower pole. There is 2 huge vessels that vascularize the lower pole, and thanks to the ICG technology, you can clearly identify that. And in this way, it's easy to isolate the 2 vessels and to save the main hilar vessels, because you have to leave a moiety. And the third part is that at the end of procedure, after clipping the vessels, you can see the line of this vascularization between the moiety that remain and the vascularized moiety that you have to remove. In this way, with the hook, we mark this line, and then using a sealing device, you can remove it. You can see clearly the upper pole that is very well vascularized and the lower pole that is devascularized. And as I told you, also using the new Rubina system, you can remain in color. And as you can see, it's easy to operate. You can see the normal ureter in green on the lower part of your screen. And on the upper part, there is the huge ureter of the moiety that you have to remove. Thanks to this technology, as you can see, you can perform a safe surgery, avoid danger for the other ureter. And this is the same also at the level of the kidney. As you add on the kidney, you can see if you inject intravenously the ICG, you can see the vascularization. This is an upper pole that you have to remove, is another case. And you can see in green the vascularization of the upper pole. To summarize, the advantage to use ICG for partial nephrectomy, you have to inject this product 3 times. The first of all, you have to perform a cystoscopy before surgery. You put a catheter in the normal ureter, and you have to inject ICG inside the catheter, and you can identify the normal ureter and you can save it. Second injection intravenously, intraoperatively. In 1 minute, you can see the vascularization of the moiety that you have to remove. Then you clip the vascularization of the moiety that you have to remove, and you have to perform a third injection, always of 2 milliliters intravenously, and you can see the line of this vascularization. In this way, you can perform an easy surgery and a safe surgery. And that's all for partial nephrectomy.
Let's keep going, Ciro. Thank you.
Okay, and then the last case is varicocele. As you know, varicocele is a debate problem because there are several indications for treatment, several techniques that you can adopt. Sometimes Europe, the technique that we can adopt is different from US. I will show you one classic case that we operate in Europe. Is a 13-year-old boy with a grade 4 varicocele according to Dublin and Amelar classification. And he has an hypotrophic ipsilateral testis, and he has left testis pain. And this is a classic indication for surgery for us. There is no spermiogram available because he's too young to do it. And for this reason, we have to decide which is the workup and the management of these children. The first option is to perform an echo color Doppler and clinical controls, because there is an option, because we have no spermiogram. For this reason, you can control until 16 years, then to perform a spermiogram and then to check the management. The second option is to perform an echo color Doppler and then to perform an open inguinal approach. This is the pathology that in Europe sometimes adopt the adult surgery, the surgeons. And the third option is to perform echo color Doppler technique and then scleroembolization. Then the fourth option is to perform echo color Doppler and laparoscopic invasive, in which you ligate the spermatic bundle, but you spare the testicular artery, or echo color Doppler and then to perform Palomo procedure in which you clips and section spermatic bundle, but using ICG. My option is the E, using laparoscopic Palomo with ICG, and I will show you why. As you know, that if you perform Palomo, you have the higher rate of success, more than 98%. But if you perform Palomo, you ligate also the lymphatic vessels. In the spermatic bundle, there are 3-4 lymphatics, and if you ligate lymphatics, you can have a postoperative hydrocele in about 20% of cases. We publish a study together with some colleagues, but after the introduction of endocyanina green, you can have an intraoperative fluorescence lymphography. In this way, you can spare the lymphatics, you have no hydrocele. To perform this procedure, you have to inject the product intratesticular. You have to always to create a solution, as I show you, and then you have to inject 2 milliliters of solution inside the testis, and you can see the lymphatics colored in green. And is extremely easy to spare the lymphatics. This is the old system in which you have a black and white view, but as you can see, is extremely easy and safe to spare the lymphatics. If you switch to colored view, you can see also the lymphatic that is colored in green, but you switch to ICG view is better. And then after the section of the spermatic bundle, you can check there are the lymphatics. And we use this technique for more than 150 patients. We have 0 hydrocele in postoperative period. And thanks to the new technology, this is the ICG Rubina system, is the special camera that permits to remain in color. As you can see, the lymphatics are colored in green, and you remain in color, and you can perform dissection easily, and you can spare lymphatics. In conclusion, some consideration. You need to use this technology, is absolutely amazing. You need the special equipment. If you use laparoscopy, you need the camera and the optic, or you need, if you have an XI robots with FAR5 system, for sure a vial of ICG. The timing of injection change according to the indication. As for cholecystectomy, is the only indication in which you have to inject in advance the day before. For this reason, you have to hospitalize the patient the day before surgery. For all other indication, kidney, varicocele, nodes, or tumors, you have to inject intraoperatively. There is a real advantage for surgeon, no adverse effect in our experience, and you can use the vial for 6 hours. This is the main indication. For me, cholecystectomy, partial nephrectomy, varicocele are the best indication, but also lymphomas, tumors, or to check the vascularization of anastomosis is others indication. You have to develop this. And in conclusion, I think it's a safe and useful and versatile technique to adopt in pediatric MIS to have a better visualization of surgical anatomy. is absolutely amazing. You have to use it above all for cholecystectomy because you can avoid complication, and above all can help surgeon to reduce complication, for example, for cholecystectomy, in which you have few cases per year. And I think that this technology can be considered in selected cases, as you can show you, to increase safety of laparoscopic procedure. And that's all.
Thank you so much. That was outstanding. Any one comment from any of the faculty or panelists that?
I just have a quick question. Can you overdose on that, Ciro? Like you said, you get three injections for the kidney surgery. Is there a maximal dose you can give?
There is no limit. As you know, this technology was used, I think, more than 5 years ago from adult surgeons. There are a great study performed from Jacques Marescot at IRCAD as for a cholecystectomy, and there is no limit for the dose that you can adopt. I think there is a lot of indication, and probably we have to discover other indication. I know that Steve Rothenberg adopt this technology also for tumors. We adopt to identify nodes for lymphomas, or to check the vascularization of the anastomosis. As for the partial nephrectomy, the first injection is inside the catheter. For this reason, is not intravenously. And then the other two injections are intravenously, but there is no problem because it's secreted by bile juice.
So this obviously, Ciro, thank you so much for coming. Mac, thank you for moderating that. There's obviously going to be a million questions. I think we've seen today that ICG is definitely something to be paying attention to. This is something that every day we're finding more and more uses. We can probably go through all of us and figure out different cases that we've tried it on: thyroids, thoracic duct leaks, all these different things. So it's really, we're getting more and more. Next year, we'll probably know more. Thank you for that incredible presentation, Ciro, and thank you for joining us from across the ocean.